with preventing surgical site environmental cleaning. Just a very quick tip. After the street presentation, we will have almost 15 minutes to answer your questions through the speakers panel. So you are kindly requested to put whatever question you might have in the chat box, and then it will be submitted. We will receive it, and at the end of the presentations, we will have enough time at least to answer and reply to most of the question. If there is any kind of question that is not replied, we will make sure that it will be replied, and we will use your registration emails and send back the answers to everyone for this one. Having saying this, I would like now to thank you so much again for your attention, for your valuable time, and I will leave the stage now for Dr. Nagwa. Please, Dr. Nagwa, go ahead.
Thank you, Dr. Maged, for introducing me, and I'm really happy to join this event today, and I would like to thank as well the organizers. Let's go for our subject of today, which is the bundle approach for surgical site infection prevention. First, I would like to declare no conflict of interest. After this session, you will be able to know that safe surgery is the result of a multifaceted approach for many partners working together in healthcare settings, and that surgical site infection prevention bundle is one of the bundles for healthcare-associated infection prevention. And the identification of local barriers to implement surgical site infection prevention bundle includes the change and the adaptation of the new behavior. And the anti-sepsis in surgery is not only for the surgical team, but it includes the patient as well. Surgical site infection prevention has become in the forefront of infection prevention initiatives, and preventive measures have been recommended by best practice guidelines as published by the WHO in 2009. Defining the surgical site infections as infections occurring up to 30 days after surgery or up to 90 days after surgery in patients receiving implants. It is affecting either the incision or the deep organs at the operation site. From the anatomical point of view, the incisional surgical site infection is further divided into superficial and deep, and the second type is the organ space as classified by the CDC NIST system. Regarding the pathogenesis or the occurrence of the infection, there are three factors interplaying together, and they may assess the risk of occurrence of surgical site infection. First is the dose of the bacterial contamination or the bacterial load. Second is the virulence of this bacteria contaminating the surgical site. Both together are working against the resistance of the host or of the patient. Surgical site infections comprise up to 12% of all hospital-acquired infections. This is a proportion. This is not a rate. So among all hospital-acquired infections, we have 12% of SSI. It occurs when bacteria from the skin, other parts of the body, or the environment get access to the incision made by the surgeon and multiply in the tissues, leading to inflammation, swelling, fever, and pus formation. But we shouldn't be surprised that SSI in 80 to 90% is endogenous in source, while only 10 to 20% account for the exogenous sources. For most SSIs, the source of pathogen is the endogenous flora of the patient's skin, mucous membrane, or hollow viscera. When mucous membranes or skin is inside, the exposed tissues are at risk for contamination with endogenous flora. These microorganisms are usually aerobic gram-positive cocci like the staphylococci, but may include fecal flora like anaerobic bacteria and gram-negative aerobes, and when incisions are made near to the perineum or groin. Despite the fact that every surgical site could be contaminated by the end of the surgery, Luckily enough, only few become infected, and we all know the cause, because the patient, before being ambulated from the surgical or the operating table, he had been put under an umbrella of antibiotics. Criteria to define the surgical site infections are based on the clinical and laboratory findings. And for the lab, we should do swab from the pus or the oozing from the wound, and to do culture, microbiologic culture, and sensitivity. These three components represent the steps or the checklist, the main checklist to prevent surgical site infection. Starting by the preoperative planning, then intraoperative technique, and postoperative care. The CDC recommendations for surgical site infection prevention have put these three components into more details, like preparation of the patient and skin antisepsis, surgical scrubbing for surgical team members, management of infected or colonized surgical personnel, and antimicrobial prophylaxis. Then comes to ensure a proper and accepted ventilation in the operating theater, the cleaning and the disinfection of the environmental surfaces, and to validate this cleaning process and decontamination process by doing microbiologic sampling. Then the sterilization of surgical instruments, surgical attire and drafts, asepsis and surgical technique. Then the post-operative incision care. This is the main checklist, but if we are going to implement a bundle, we have to set a strategy. So the team should prepare the way for change by studying the current process and educate the affected parties. The next step is to begin testing the SSI bundle. At the beginning of the implementation, it is suggested that teams conduct small tests of change to start improvement of the work. With this approach, team members can learn quickly what works and how changes need to be refined before full implementation. And we call this the pilot testing or the pilot study. Begin using the bundle with one patient from the time of admission for surgery, and work with nurses caring for the patient to be sure they are able to follow the bundle and implement the small checklist. Make sure that the approach can be carried over from shift to shift to eliminate the gaps in teaching and utilization, and process feedback and incorporate suggestions for improvement. Once the bundle has been applied to one patient and subsequent shifts, increase utilization to the remainder of the selected work area. So we will start by selected area and then we will expand it to other areas. But when we are sure that there was an effect of the implementation by minimizing the surgery resistance and other barriers for improvement. So the following table in my next slide will identify some common challenges and suggested solutions. The first of them is the fear of change. And we all know that we are all happy to work in our comfort zone. And we all have this fear of change, but we should know as well that the antidote of fear is knowledge. So, informing staff about the deficiencies of the present process and provide reasons about the potential and benefits of the new one would potentiate this knowledge. The uneven acceptance of the new practice or the patchy acceptance of the new practice, and for this we have to engage opinion leaders among physicians to review medical literature and feedback data on a surgeon-specific level, and work first with early adopters and use their stories to convince the majority. And thirdly, the communication breakdown, and this will be achieved by the ongoing education of staff. What's a bundle? It's a structured way of improving processes of care and patient outcome. It's a small, usually 3 to 5, but critical set of procedures. All are evidence-based, which when taken together create much improved outcome. It's like the 20% effect of the Pareto chart. Knowing the risk determinants of surgical site infection, a bundle could be formulated in order to prevent and control this type of healthcare-associated infections. So, our bundle would include the tight glucose control, additional skin antisepsis, policy for antibiotic prophylaxis and empiric treatment, especially with dirty class of operations, normothermia, and screening for MRSA. About the microbiologic aspect of surgical site infection, according to NIST system, the distribution of pathogens isolated from SSIs has not changed markedly during the last decade. We have still Staphylococci, coagulase negative staph, Enterococci, and Escherichia coli are the most frequently isolated pathogens, and also we may find Candida albicans. This is an illustration of the mostly common encountered microorganisms, but what is new lately is the fact that these microorganisms have become more resistant to antibiotic therapy. We did testing of these isolated hospital strains of microorganisms versus a set of commonly used antiseptics using the modified standard British European test method. And for this we used alcohol 70%, chlorhexidine gluconate 4%, povidone iodine 10%, and hydrogen peroxide 3%. And we used them versus hospital strains. And we found our results conforming with what was published with the CDC in 2003. And we have to highlight here that the povidone iodine has got the privilege to be used for skin preparation of the patient and in the same time for surgical scrubbing of the surgical team. And more, it was the only one to have excellent effect like residual activity and have from excellent to good effect versus the most commonly encountered microorganisms. There is another additional factor that may cause this surgical site infection, which are the residual dead tissues, sutures, and other foreign material, or the presence of strain. This may amplify the consequence of the bacterial inoculum, and in order to avoid the suture of being a risk factor of SSI, recently there is a new antibacterial suture coated with a well-known antiseptic, triclosan. However, this triclosan has kind of innate or intrinsic resistance from the Pseudomonas aeruginosa bacteria, but it has got an excellent effect toward the Staphylococci, whether methicillin sensitive or methicillin resistant. And this was the testing in our labs of the coated sutures with triclosan. And this testing was also in the presence of our used set of antiseptics like alcohol, chlorhexidine, povidone iodine, and hydrogen peroxide. And these have been the results, and from these results we can conclude that there was a synergistic effect or activity between the coated sutures and the most commonly encountered or the most commonly used antiseptics. So this is our bundle, mainly these three components, like a concise, very small checklist to be used fully. We don't accept the compliance less than 100% of implementation of these three components or elements. We should apply before surgery for any patient undergoing surgical procedure in our healthcare settings. The tight glucose control, the potentiation of skin antisepsis, and we will explain in the next two slides what we mean by potentiating or adding to the skin antisepsis, and the additional policy for antibiotic prophylaxis and empiric treatment for dirty operations. So our recommendations for the potentiated skin antisepsis would be to do it twice. Primary, one in the ward to do antisepsis after the patient has took his shower, of course, to do antisepsis in the site of the skin that is going to be the incision for the surgery with povidone iodine 10%, and a second time on the table in the operating theater, again with povidone iodine. So like this, we would eliminate all contamination of flora present on the skin of the patient. Then use coated sutures for the surgery. Then for contaminated and dirty classes, we should use the appropriate antibiotic prophylaxis, specifically whenever gram-negative bacteria are suspected or evident. Safe surgery saves lives, which is the theme of our event today, was part of the World Alliance of Patient Safety of the WHO in 2008. And it did a lot for the prevention and control of surgical site infections. And I have to mention that a patient coming to a healthcare setting or a hospital to undergo surgery, this patient is a competent patient. He is immune competent, so he shouldn't go with an infection. So we have to do our best. We have to work on good antisepsis. We have to work on his glucose level. We have to fulfill the bundle 100% to save this surgery and to follow the recommendations of the WHO. Thank you.
Thank you so much, Dr. Nagwa. I don't think that I am the right person to say how much the presentation was great, and I do believe all the attendees are sharing the same. Thank you so much for this great presentation. And as I said, we will answer all the questions at the end of the presentation. So now let me to welcome Dr. Amina for the second presentation. Dr. Amina, the stage is yours, and we are waiting for your great presentation as well.
Hi, good evening, everyone, ladies and gentlemen. My name is Amina Hassan. I am a clinical resource nurse. I have master in healthcare education. I have passion working in operation theater previously. I have passion in infection control. Today, I would like to share my knowledge with you regarding infection control in the operating room. This is slide just to declare a declaration of conflict of interest, that we don't have any conflict of interest doing this presentation with Modifarma. Let's see here, we start. What is the most dangerous scene you can see here? Is it the painful picture of the airplane crash you're seeing, or the operating room? We know as healthcare providers, if you're used to be in an operating theater, we dress nicely every day, go and peacefully start our surgeries, and we don't feel like the place is so dangerous for us or for others. And instead, if we will see on the other hand, the painful picture of the airplane, which is more scary or more dangerous if we will compare it to the picture of operating room. But let us see the facts now. According to the report of Medicaid or Medicare, the report to Error is a Human in 1999, Institute of Medicine, more than 100,000 people die because of healthcare harm. And this is equivalent more than 10 jumbo jet airline crashing every single week. In United States alone, 99,000 people die because of the nosocomial infections every year. And hospital-acquired infection is estimated around 30 million $30 billion cost every day, which is 4,600 patients get infected and 271 patients die, and that is only in USA. So we do surgeries like every day. Around 27 million undergo surgeries, equal to 500,000 will acquire AS, surgical site infection. Let us see the mortality risk among patients with surgical site infections if they acquire surgical site infection with us in the operating room. A patient with a surgical site infection is 5 times more likely to be readmitted after discharge. This is according to the WHO guideline for safe surgery in 2019 and the 2003 infection control article which is presented. And 2 times more likely to spend time in ICU and 2 times more likely to die after surgery. And mortality risk is higher when surgical site infection is due to MRSA. A patient with MRSA is 12 times more likely to die after surgery, actually. So this is the fact that we are having about the mortality rates among patients with the surgical site infection. So today, more people die because of the hospital-acquired infection than of car accidents, plane crashes, AIDS, and breast cancer all combined together. How we get infection? In order to get infection or spread infection in hospital or to get hospital-acquired infection, there is a chain. If it is maintained, it is not broken, then we are spreading the infection in our healthcare. First of all, there should be a causative agent. Let us have any scenario. Let us say hepatitis B, for example, and there is a reservoir, a patient that you are having coming in your organization, having that causative agent. Then portal affects it if you are doing any procedure to this patient. Let's say if you are doing surgery to this patient. And mode of transmission, it is you as healthcare provider, the instruments that you are using, your hand hygiene practices could be the mode of transmission, and portal of entry to another susceptible host if you are having. So if we complete this chain, we will help in spreading an infection. In order to break this chain, what do you think? What is the weakest link in this chain? I guess everybody knows the answer here. The mode of transmission is the weakest link here to break the chain. And as healthcare providers, we hope that we can eliminate this entirely. And the goal of infection control is to reduce the number of the causative agents of infection. And you know what is the simplest method to break the mode of transmission or break the chain through this link? It is the hand hygiene. And according to the AORN guideline of hand hygiene, as we know, organism multiplies every 20 minutes. And we are having moments of hand hygiene as per WHO guidelines. And in operating theater, or personnel should perform hand hygiene before and after any patient contact, before performing a clean or sterile task, after risk of blood or body fluid exposure, after contact with patient surroundings, when hands are visibly soiled. So there is a difference between hand hygiene and alcohol-based hand rub, of course, but at the end we are making a hand hygiene before and after eating and after using of a restroom. So these are the steps that we need to follow in order to prevent infection with the simplest mode, or to break the chain of infection with the simplest mode of transmission, the simplest or the weakest link of transmission. Here let us discuss the factors or challenges that we are having in operating room, which can put our operating room at risk. So what are the safe operating room practices that we are having? which will prevent the surgical site infection. Let's ask this question. Is our operating room safe? If I answer all these questions or I maintain them, I could say that yes, our operating room is safe. First of all, we will speak about the traffic control and number of the staff in the room, and we'll discuss why the traffic control is really important. Surgical safety checklist and how surgical safety checklists play a role in preventing an infection, surgical care improvement program, or whatever you say, surgical site infection bundles that you are having. The bundle could include the things which you or your organization already agreed based on the gaps that you have found. Could be hair clipping, warmers that you are using for the patient to prevent hypothermia, proper oxygenation of the patient, surgical prophylaxis antibiotic, polycatheter removing less than 48 hours, and glycemic control. Room turnover and terminal cleaning, we will discuss also about it to see how it will make our operating room safe. Surgical techniques and handling tissues, instrument cleaning and sterilization, and at the end, storage of supplies, supply bin, carts, tables, and OR equipment. So let us start with the zone of operating room. How many zones do you think we have in the operating room? And how you apply infection guidelines in every zone. Those who are working in the OR, of course, they are aware about their zone and they know what to wear in this zone. Just reminders for them. Let us see this slide. Now, we are having mainly 3 zones in the operating room. First is the non-restricted area, which is the entry points to the department, such as the locker rooms, changing areas, supply delivery area, preoperative admission areas, and phase 1 and phase 2 post-anesthesia care unit. And in this area, it is always advised or encouraged, it is not encouraged to wear the surgical attire. Even street clothes are fine, are permitted. PPE, it is not indicated, only if it is required, if there is any kind of infection, for example. And within this unrestricted area and PACO, there should be around 6 air exchange per hour. Then we have the semi-restricted area or the second zone. It is the peripheral support areas for clean and sterile supplies. It is the work areas for storing and processing instruments. It is the scrub sink areas that you are having, scrubbing your hands, the corridor which is leading to the surgical suites, the locker rooms and sterile processing areas. Here we have traffic should be limited and only for the authorized people, like the people who are working in the OR, the surgeons, the housekeepers which is there in the OR and with the specific OR attire. They should wear the surgical attire. And the attire could be the head and facial hair. If it is not covered, it's fine, but the other surgical hospital laundered surgical scrub, it is recommended. And this is sterile storage and clean workroom should be at minimum 4 air exchange, and the contamination room has to be minimum of 6 air exchange. And we come to the last zone, which is the restricted area, the third zone with us. It is the surgical suites where you do the operation and the invasive procedure and operating rooms. You need to have a proper surgical attire, cover all the head and facial hair should be covered, and non-scrub personnel should wear long sleeve scrub tops, mainly if we are doing the prepping. Mask is required all the time where open sterile supplies is there. And all restricted area is maximum 20 air exchange required of the manufacturer of heating, ventilation, and air conditioning HVAC system. Traffic control during surgery. Why do we control the traffic? We know that when operating surgeon is starting and there is open wound is there, the more the people they move around, the more the air, the turbulence will be there, and the bacteria will be in the air, and they can settle on the wound, which can cause infection. So we want to avoid that. We want the people who are not necessarily involved in the surgery, they are going and opening the door. So we need to know who is in the surgery in the beginning, and we close the door. Only entry and exit of the patients and the personnel who need to be in the OR, they are there. There are some strategies which could help us. Actually, we can follow to prevent door openings, and sometimes we cannot avoid. Sometimes there are a multidisciplinary team are there, anesthesia, technician, they need to get something they want. But we need to be advocate to our patient. We know how important it is, and we need to put a structure and guideline how to control that. Pre-planning, it is really important. Everything is planned, surgery is planned, what we need for this surgery is planned and prepared ahead of time, so we don't need to go out and get it. Preference cards are really important. Now I know what the surgeon needs, it is all there in the preference card. I don't need to go out and get it later. It will help me in limiting the door opening. Confirming that all supply present before we open the incision. A sign on the door for restricted traffic. There are sometimes interns, there are sometimes student nursing or medical students, they are there, they would like to come. They need to take prior permission, limited number of the people, and also they cannot come and go inside the theater. So signage also as a reminder for the people. Communication without door opening, if we will have some kind of technical communication inside the room, if we want something, there are in the OR are designed actually, even if you can give something without opening the door through some windows. Locks open from inside only, and taking breaks, so we don't need to take a break during the surgery, and proper education and awareness to the people. Sometimes the multidisciplinary team are there, or anyone who are coming outside the OR sometimes for some training. If they are not properly trained and educated, they can violate the rule, not because they want to violate it, because they are not aware of it. So education is really important. Okay, surgical safety checklist. Now, how surgical safety checklist has an impact on the surgical site infection. Let us watch this video about surgical safety checklist, and I'm going to discuss about. This is just how not to do the surgical safety checklist. So everybody saw this nice video. It could be a fact in some areas. I don't know what is going on in your operation theater, but the place where I work, it was previously. I can say now a lot of improvement done with because we are accredited hospital now. We applied the surgical safety checklist, but previously surgical safety checklist was not as applied as now. And why surgical safety checklist is really important? We have seen here, if we will see the elements of the surgical safety checklist, just to give you a knowledge, we have 19 elements. If we will go to the sign in, what is the thing that you need to consider if I'm only thinking about surgical site infection, which surgical safety checklist can help me. If you can see here, you can see the blood loss. If I'm going to give a patient antibiotic, if the blood loss is more than 500 ml, so I need to consider the redosing of the antibiotic and for these patients. So also, if we will see in the timeout section, one of the most important bundle in the surgical site infection is the antibiotic. Has antibiotic prophylaxis been given within the last 60 minutes? We saw now in the video, Amit, he was just ticking, then they found out the antibiotic was not given. So this is one of the important bundles that we are having. Also, of course, sign out also it is important with all its elements, counting and checking the instruments are sterile or not, has a sterility indicator is there. So this is also highlights for the OR nurses to check the indicators inside and all the instruments are sterile. So now I want to show you another video how properly we need to do it. So we have seen the surgical care improvement program. Most of the things is covered in the video of surgical site infection. Surgical prophylaxis, selection at this time, discontinuation, and a stop of when we are stop when the incision is closed. And also, it was mentioned about warming of the patient. It was there in the timeout. glycemic control, it's one of the important SSI bundle. Actually, it is also mentioned in the timeout of the patient. Then increase oxygen. We need to put the patient the oxygen for wound healing, and also removing polycatheter within 48 hours. Hair clippers is one of the surgical care improvement programs. As far as we don't need to remove the hair, it is not recommended. If we really it is really needed, then we remove the hair on the location outside the operating room always. And if in case we need to remove in the OR, for example, whenever possible, it should be outside. For removal of a stray hair from clipping should be done using current method like tape and suction while clipping on top of a disposable underpad. And remove and dispose single-use clipper head immediately after use and clean the clipper unit according to the IFU or instruction of use. And there is some innovative things we can use. It's utilizing innovative vacuum-assisted technology for safety removal of the hair before surgery. Surgical attire. Where and how we do. Of course, surgical attire, they are one of the important factors in operating room. We should wear hospital-laundered surgical attire, and a risk of pathogen being carried of the scrub attire if we are doing it home laundered. Sometimes it is challenged. Now, if in your hospital and your organization, they are having contract with a third party and how they are laundering your surgical attire, if it is not coming stained or the color is changed, because there are people who are really concerned how they look in the surgery. So we have to consider if they are bringing with the third party their scrap suit is being lost, sometimes it's being stained, so they prefer to take it, and they will not tell you that they are taking it at home. So you should see the root cause, why the people are taking their clothes home and why they are laundering at home. If you are providing a laundering third party contract, then you encourage the people to launder their surgical attire. Even if you are having the policy, sometimes the human factors, we need to consider it. And if we are wearing the surgical attire inside the restricted area, let's say in the OT, head covering is really important. We know that as per guidelines, normal individuals shed more than 10 million particles from their skin every day, and approximately 10% of the skin squams carry viable microorganisms, which estimated individuals shed approximately 1 million organisms from their body each day. So personnel entering the semi-restricted and restricted area should wear the proper surgical attire, even covering the sometimes we have short sleeves if we are having open wound or doing prepping. Actually the new recommended guidelines of 2021 of AORN that to wear surgical jacket if we are doing prepping and we are in the restricted area. Hair, facial hair and head cover, and we can see the classical hair hood that some surgeons are using or nurses they are using. That means you are not covering the full hair, and part of the hair is exposed also. So clean surgical head cover or hood that combine all hair and completely covers the ear, scalp hair, sideburns, and nape of the neck should be worn. Sometimes some healthcare providers, they are just removing their head cover and keeping in their lockers to reput it. It is not recommended, and it shouldn't be there. Should be using the disposable one. Hair colonize the bacteria, and the bacteria will be shed. And if you are especially working in the restricted area, as we said, long sleeves. It is recommended if you are dealing with the restricted area. It is the same concept. If you are covering your hair, if you are having short sleeves, it's not covering all arms, especially for personnel who are having hairy hands. So hair could go to the sterile items. So it is preferable to wear surgical jackets when we are preparing or packaging the surgical items. And also it is recommended when we are doing prepping of the patient. Cover apparel, clean or single use. Evidence does not support wearing cover apparel to protect scrub attire from contamination. Lab coats can be contaminated with large number of pathogens. So if you are going outside the surgery, it is recommended. If you are in urgent to go outside wearing cover, when you come back, you have to remove your change it with the fresh laundered surgical attire. Sometimes medical reps, doctors, they can bring backpacks or briefcases. It shouldn't be taken inside the restricted area at all. It could be there in the non-restricted area or in the offices, but not in the operating room, never. Environmental cleaning is one of the other important things that we need to consider if we are thinking safe operating room and how we need to clean. We have different type of cleaning actually in OR. If we think about OR, in the beginning, daily in the morning, we do damp dusting. Between the cases, we do turnover cleaning, and we have terminal cleaning at the end. But let us see how we do clean actually, and how we do train the people who are really cleaning. First of all, we need to have a schedule. We need to have defined assignment who clean and what they will clean, and what items we are using to clean. It is especially microfiber clothes versus anisani clothes that we are using. It should be lint-free clothes that we are using when we are cleaning the OR. If we are trying to spray, for example, you are using your Vicron or antiseptic solutions, it shouldn't be with the spray because spray will spread the bacteria. So even if you are having the spray, they can spray on the clothes and wipe the operating room. And this should need to be educated to the housekeeper and whoever is disinfecting. And we need to evaluate the contact time or dwell time of the disinfectant we are using. I'm not going to tell you what is the time. It depends on the manufacturer instructions that you are having. End of the procedure cleaning, we can see after every patient, the high touch areas in purple need to be clean. Every patient, if it is used only, that is in light purple. If we are having some attachments, some things which are not used for all patients, then only if it is used, we will clean in the turnover time. And we have enhanced cleaning if we are having any infectious case. So we can include all these yellow hands also. And the floor and the walls are cleaned in the turnover time whenever it is soiled already. If we are having terminal cleaning, everything should be cleaned at the end of the day when all surgeries are done. And we need to have a scheduled cleaning, what to be cleaned. Not all area and OR and procedural area are cleaned daily. Each facility will decide how frequently they do clean, either weekly or monthly. So scheduled cleaning should include cleaning the soiled storage area, the corridors, elevators, so all these areas. And we should have a schedule and documentation. We know that at healthcare, anything you do, you document. If you don't document, as if you did not do it. So schedule cleaning for scrap sinks, walls, ceilings, privacy curtains, pneumatic tubes, launches, workstations, so on. Coordinated cleaning, it's a cleaning of the following equipment will need to be done along with facility maintenance like eye wash stations, ice machines, refrigerators, sterilizers, ventilation ducts, and routine maintenance of these items is really necessary. Equipment must be cleaned before bringing it in the patient area. As we said, checklists and log sheets are really important. Schedule cleaning and need to be documented all the time. As evidence-based research, technology of OR air and environmental disinfection using UV lights and movable air treatment system with HEPA filters or dry hydrogen peroxide air. According to the researchers, it is really recommended also. Instrument cleaning and sterilization, I'm not going to go deep with these things. It is purely CSSD, but we need to know that anything it is not well cleaned, it cannot be decontaminated. The role of the OR nurse here is like not to allow the blood dry on the item before sending it to the central sterilization department through wiping it simply in between with the irrigation water. Never ever We wipe with saline, because saline can be corrosive to the items, and not with the spirit also, because it's kind of a fixation item to our instruments. So there is difference between cleaning and decontamination. Cleaning is just removing of the visible and non-visible soil that we can do. Decontamination, removing and reducing the contamination by infection agent, that is done in the CSSD. But pre-cleaning we are doing in the OR and spreading the items with the spray gel before it goes to the CSSD. So we need to inspect the items for all lumens and group. It is recommended if you're still working with the CSSD SEM nurses, ultrasonic washers, pre-soaking and rinsing of the tissue and blood in the enzymatic solution, like we said, or during surgery we'll just wipe it. Reduce immediate use of sterilization and purchase additional instruments and trays. Now, how to improve our system if we are having high SSI rate? I'll just briefly go with you. It is really recommended the multidisciplinary team to be involved. It is not only the nurse's job or doctor's job. Everybody needs to be involved, even the infection control practitioner, the healthcare quality facility, environmental services, CSSD, surgeon, anesthesia. Everyone should be in a round table and discuss and evaluate what is their structure, what is the policy procedure, needs to be reviewed, facility design, patient risk factors, infection rates that you are having. Are you using any innovative infection prevention products or not? So all they have to sit multidisciplinary stewardship team and do the brainstorm, engage all the clinicians, do root cause analysis, find out what are the problems in your organization. I just showing you this RCA root cause analysis fishbone. You can see the problem related to the organization. If you have financial constraints to buy the more innovative products, for example, for leadership, you have problem with the pre-operative team factors is there, your prep factors you are having, patient factors you are having. All these factors can lead to the surgical site infection. You need to have your unique root cause analysis and find out. After that, you can build your own bundles. Always bundles are unique also to every organization based on the gaps that you are having, the procedure or a specific procedure you have, and your compliance level. If you are having a bundle which is one of the surgical site infection bundle, it is there, then you can renew your bundle and have your new bundle and work on it. Through that, I think I have done with this presentation. Thank you very much, everyone. If you have questions, I'm here and ready to have, and I'll be happy to have your question. Thank you very much.
Dr. Amina, thank you so much. It's really amazing that how the clinical practice is reflecting in your presentation. I do believe every healthcare professional is dealing with this on day-to-day practice. I think he benefits from your kind presentation. Thank you so much again for this one. Now, last but not least, allow me all to introduce Mrs. Anna for the last presentation, and I do believe it will be as much as the same quality of the whole presentation that we have today. And after that, immediately, we will start the session of question and answer. Thank you so much. Ms. Anna, the stage is yours.
Good morning. My name is Anna Furanjan. I'm the Executive Manager of ICAN. I'd like to speak to you today about how to prevent surgical site infection with decontamination and environmental cleaning. And I just want to reiterate the declaration of no conflict of interest as a consultant and occupational representation for any pharmaceutical companies. What we want to talk today is about how we as nursing and as healthcare workers can stop the surgical site during the era CSSD. And we spoke about the principles of surgical site infections. Dr. Nagwa had a lengthy, very interesting discussion and told us everything about the surgical site infection. And what we want to do is we want to avoid the introduction of microorganisms into the surgical site. And this we can do with our equipment, decontaminate the skin and minimize airborne particles. And Professor Nagwa also spoke about the multiplication of microorganisms at the operating site and how we can prevent this by assessing the wound post-operatively. But what I want to speak to you today is about the growing number of healthcare facilities in Africa and how the use of disinfectant in sterilization has increased across Africa. And we've seen that Africa has over 622 healthcare facilities in 53 countries. And the need for getting more disinfectant and antiseptic has risen. But a lot of people don't understand what is the difference between a disinfectant and an antiseptic. An antiseptic are used to kill pathogens on an inanimated surface or instruments, while an antiseptic can be used as a chemical to kill pathogens on live tissue. For example, the alcohol hand rub that we've been seeing going around since the pandemic. They also use chlorhexidine gluconate and providine iodine for skin preparation during surgery to prevent further infections. So what we need to look at is decontamination. Decontamination is a whole process. And this is to make sure that the instruments they are going to use in the theatre operation during this time to prevent infection, we need to make sure we understand where it comes from. This is to remove all soil and pathogenic microorganisms from objects that are safe to handle and especially subject to further processing. But it's safe for our patients and it's safe for our healthcare workers working with the instruments. But at the moment, the whole process encompasses cleaning, disinfecting, and sterilization. And I'm going to talk a little bit more about each of these. So what is decontamination? This is a process that we follow to make sure that any medical device that is going to use on the next patient is safe. For example, the decontamination of a vaginal speculum between patients or the decontamination of surgical instruments between operations. Why is it needed? This is required because we need to remove all the microorganisms before the medical device or any equipment can be used between patients. Microorganisms can be transferred between patients by direct or indirect contact with inadequate decontamination happening in our healthcare facilities, and thus result into healthcare associated, or as we are talking about, surgical site or surgical associated infections that can happen. So when we first need to do this, we need to first clean. And cleaning means remove all the organic material, all the foreign objects that could be around the instrument. This could be dust, soil, pieces of blood, secretions, excretions, anything that the medical device got in contact with. And then after you've cleaned it, and then you wash it with soap and water, you will then follow the next process by disinfecting it. And we will see later on using the Spalding classification to make sure that we reduce the number of viable microorganisms to less the harmful level on the instrument before we can start using it. And then when we are knowing the type of instrument, is it critical, non-critical, or low critical, we would follow the following step by validating a process, putting it through the autoclave to make sure that this object is free of any viable microorganisms, including viruses and bacterial spores, but not prions. Cleaning and disinfecting can remove a lot of microorganisms. It can kill viruses, and disinfectant further make sure that it kills the virus and some of the bacteria that are left behind. But only spores and the smaller microorganisms of viruses can be killed through sterilization. So when we consider what type of cleaning or disinfecting or decontamination we're going to do, we look at the type of organism and the type of instrument we're going to use. And here we will see this is a type of a summary of the Spalding classification. We look at the type of instrument that we're going to use. Is it a critical or semi-critical or non-critical instrument? We also look at the number of bioload onto the instrument that could cause a possible infection. We look at the type of organism that we could find in this area. It could be on the instruments, it could be on the environment in theatre or in the sterilization department when we are preparing the packs for theatre. And these could be bacteria, spores, viruses, or prions. And then we also look at the type of patient that we're going to use this instrument on. And during the theatre, when they are operating on a patient, it's quite invasive because we normally cut through the normal skin, we break the defense from the patient, and we insert this into a body cavity that's not used to these instruments. So, when we look at cleaning versus disinfection, both reduces the bacterial contamination. Disinfecting in the reduction of microorganisms. Surfaces you can never disinfect adequately because it's not properly cleaned. So if I use the surface and I don't clean first, I just pour some disinfectant over this, I'm just actually wasting my time. We have to first clean with a detergent and water or soap and water, and then you can take a wipe and you can wipe it down with a disinfectant. Cleaning prepares the surface to be disinfected. Cleaning removes the dirt and organic material, which actually, if you leave it there, will make sure that the disinfectant can come in contact with all the surfaces to ensure that it actually decontaminates that surface around where you want to work. And then while we clean our instruments, if we look at our instruments, we need to make sure that between all the little grooves and all the little handles, the opening and closing of the instrument, that everything is removed. And that's why staff are trained to make sure that they do inspection. When they wash the instruments, they make sure there's no splashing, they put on the proper PPE, they protect themselves, they wash under the level of water, and then when it comes out, they do inspection to make sure that they removed all the possible organic material or possible microorganisms that they can see with the eye. They make sure that they do not inactivate the disinfectant by leaving some soil on it, because they're going to follow the disinfecting process after cleaning. So when they clean, during our CSSD, we are shedding skin scales. And we all know that on the body, we need to have a lot of microorganisms that are safe for the body. But if that microorganism moves towards another area, you would see that that could cause an infection. It's not always a microorganism, but it could be a skin scale or some fluff from the material that comes into the instrument, and that can actually then lead to an infection, which could be then seen when we actually have the patient during the CSSD packing cycle, or when they inspect the cycle, or when they wash the instruments. They didn't follow possible procedure, and some of this fluff, and if you can look at the hand of that person, you see a green slight of look like dust, and that settles in the CSSD if we use a lot of these green cloths close to our instruments, and that can then lead and go into the cavity when we put in the instrument into the patient's body, and that open up then a new possible organism that could be causing a surgical site infection for us. So when we transmission of this pathogens, when we look at a surgical wound, we cut through the patient's normal defense mechanism by opening up the skin. We allowed an open area for bacteria that can be implanted by the hands of the surgical team if they didn't provide proper hand decontamination and putting on their gloves properly, if they use instruments that are not properly cleaned, or people didn't inspect and making sure that there's no small speck that could have been burned through the sterilization cycle onto the instrument, and as soon as it's then put into the cavity, it becomes loose and it stays behind, and this could then lead to infection, what we then can see next. So if we look at our CSSD, we've got a lot of areas that is a very nice environment for organisms to grow. And you get a lot of gram-negative bacteria, and if you look and see, we've got a warm, wet environment, and this is a grow place for gram-negatives that can grow. And in Africa, we see a lot of times that we're starting to reuse instruments or material that should actually not have been used second time. We look at the oxygen mask, we look at some tubing. If you can see at the bottom picture, there's some speculums. Sometimes we soak them into water. We don't open it up completely, making sure that all the organic material is left is removed, and then we put it through the autoclave and we think it's safe to be used. If we don't make sure that our environment where we are using our instruments is clean and not damp, we can actually have a growth place for gram-negative bacteria, like the E. coli, Klebsiella, or possible Pseudomonas that could cause a great deal of problems for our patients and can even lead to their death. So while we are cleaning this, is very important, and we also, and I cannot reiterate this more, that cleaning is one of the most important steps that we cannot leave out. And by cleaning, we're making sure that we remove most of this. We then follow this situation and making sure that any device we are going to use is very vital to ensure our patient safety. Proper cleaning alone will remove up to 80 to 90% of microbial contamination onto the instrument if we do it properly, and not just dumping it into a disinfecting solution and think that will remove it. It is vital that we remove this by a physical method, by taking a cloth, remove it physically, look at all the instruments, then we wash it properly, inspect it again, and making sure that there's nothing left behind before we then proceed to wipe it down, put it in the package that we are going to put through the autoclave, making sure if it can allow to have any penetration of all the steams. So the way that we are also packing, putting it through the autoclave is very important to ensure that when the staff in theatre open up these instruments, they are actually safe for them to use. They are working properly. We check that there's nothing left behind and that they can actually then safely use this. And we can use this by heat. When we clean, we use normally hot water. It won't be able to be about 45 because you won't be able to wash with your hands in there. Into a patient, you can actually introduce by just using a rusty or an instrument that has been damaged into the patient, that this can actually lead to further infection. We making sure with the inspection, they do it normally quite detailed, to making sure that under big magnifying glass that they see all the different hinges, all the little grooves, that everything can open and close, and it's still sharp, it can still cut, and then they will follow the manufacturer's instructions for how to clean it and how long it should be exposed to the cleaning material. The don'ts about cleaning: never use just disinfectants on instruments. It could be quite corrosive, and we see a lot of medical devices need to be destroyed because of this, because it leaves a residue that could be harmful to our patients. It can also have a toxic reaction to the staff working with this. And if you will use water over 45 degrees, it will coagulate the protein onto the material and onto your instrument, and you won't be able to see it. But when they use it again, it will come loose, and then it will create a bigger infection for the patient. Do not scrub under a running tap, as you see the top picture. If you are scrubbing like that and you don't protect your eyes and your face, you can have actually some splashing, some organic material can go into your face, and that can actually harm the staff member working with this. So if you look at the bucket inside the basket, there is a level of water, and we actually want them to immerse the instrument under the level of water and brush lightly under the level of water. When they take it out and they dry it a little bit, there's no possible illusion of splashing, so then they are quite safe. And then also never to soak this in any disinfectant as this could really be quite detrimental to the instrument and to the patient. Here's this to show you that if you get any material with a sign like this on, it means you can only use it once and it should be discarded. So we really appreciate if people, and we do understand resource limited countries sometimes have to reuse, but it's quite dangerous because according to manufacturer, it's not made to be used twice. When you choose a disinfectant for your facility, you have to look at the cleaning agent. You look at what do you want to disinfect. How would the personnel be affected, because they're going to have to use this. We want to make sure that the IPC are involved. We know that there's normally quite a tedious process, and when they decide on the company, that company will be used for the next 2 or 5 years. And if you choose the incorrect disinfectant, it can actually lead to quite a detrimental to the hospital and quite costly. Overall, we need to look at the safety for the whole environment. We need to look at the safety for the staff, and then for everybody that's going to use this. If we incorrectly use disinfectant on our environment, we can lead to disinfectant and a resistance in the One Health and even in our antimicrobial resistance and antimicrobial stewardship we are talking about. And here's all the different factors that we need to look into. We need to make sure that they can clean properly. We need to look at the organic material that we're going to be in contact with, type of resistant organisms that it can cause sort of a infection or sort of a reaction to the microorganisms. We look at the type of and the concentration that you need to use. So if it looks like it tells you it cleans 99.9%, but you have to expose your instrument for 60 minutes, you will definitely know that this is not the right one for you, even though it says it kills 99.9%, because we don't have the time to expose our instruments 60 minutes to have it safely rendered for next use. We also look at the physical and chemical factors. Want to make sure what is the type of temperature we need to use, what is the pH, can it be used on any surfaces, what is the specific time and that we need to expose it, as I said, and then also the stability. How do we store it? Is it unstable, that if it's not stored properly, or that you have to discard it after a certain period of time? And we know that, especially with chlorine that we've been used in Africa quite a lot, if it's been exposed to sunlight or it's not mixed every day properly, it has got actually quite a detrimental or no effect at all. The disinfectant use has been rising over the years, and we've seen during the pandemic the huge amount of disinfectant that has been used, and we see there's definitely a big impact on the world and on our economic impact. And as you can see that in South Africa, and I'm from South Africa, Europe, North America, and even East Asia, there's quite a high impact of increasing use of disinfectants. And we see in Africa that chlorine is being used still quite regularly. And chlorine can be used, but it depends on when and where you want to use it. So some disinfectants are not harmless. We look and see at the type of chemical that they actually inside. And this can have a short-term effect, respiratory disorders, dermatology disorders. We have a long-term effect, and then even on our environment, on our plants, on our water and our soil. So we need to really be careful of the type of disinfectants that we are just buying and think it will be good. We need to make sure that when we buy any disinfectant, that it can be used in our facility and it is proper and it's safe for use and the end user during our instrument cleaning or even in our wards for our patients that's going to be in contact with that. We've seen a lot of resistance, and all these slides are complimentary from Professor Shadai Ogunsola. We've seen they've done a systematic review in 2021, and they've looked at 28 papers, and they've realized that the resistance of bacteria against 7 different disinfectants has been found. The commitment resistant to antimicrobial resistance among clinical and important microorganisms appear to be related. So here's just an example for you to see how the buildup of the immunity to chemicals. Do we need to use so much disinfectant? So we really need to think about this. So when we are part of this, we need to start thinking, what do we want to do with this disinfectant? Where are we going to use it? Is it safe to use right through our facility? Look at our staff that's going to work with that, and then also our patients and anybody that comes into our healthcare facility. So that's why it's really important we need to do a risk assessment. A risk assessment is something that we do all the time, before the time and then afterwards, and we look at our devices. We make sure that the level of contaminant that's happening, what is the level of risk for the patients, for the staff. Look at the type of, is it critical or non-critical? Even our population, we need to look at the type of population we're going to serve in our facility. We look at our organism profile. Do we see a lot of MDROs in our facility? What is the reason for this? We look at the type of organism that we found, and then we decide, would this type of disinfectant be used? Is this safe for us? And when we are looking at the whole risk assessment throughout our facility, we will be able to see, do we really need to use so much disinfectant? Can we just clean and then follow our procedure to make sure, depending on what we are going to use it for in our facility? But we are talking about the CSSD, and here we've got Spalding classification, which is quite important, and I think this is something that everybody should need to understand. So when we go to theatre, and this is where we want to make sure that there's no surgical site infection, we will make sure that, because we're going to directly go into the bloodstream, into copies, laryngoscopy, and in airway tubing. How do we are going to clean this? Can we reuse them? How are we making sure that they are clean? So they are normally a high level of disinfectant, no vegetation formation need to be left, and a few spores that could be acceptable. If we look at our non-critical instruments, those are the ones that we can use, like our blood pressure cuffs, stethoscope, our cervical collars and thermometers, and they only need to have been cleaned or maybe wiped down with a disinfectant. So here's the different types of sterilization. It depends on the country, or if it's low or middle income countries, do they have these? But we would prefer if they have steam sterilizers, because you can actually validate, you can make sure you know and understand how the machines are working, and you've got your proper maintenance of the machines. But even for your heat sensitive devices, you need to have a different option, because you can't put them through the autoclave. And then you could have ETO gas, hydrogen peroxide gas plasma, formaldehyde gas, ozone, or even dry heat. And any of these, depending on your facility, depending on the country, and depending on the resources, you would be able to use, and making sure you follow manufacturer's guidelines when you use this for your heat sensitive devices. Then we want to just make sure one of our core components in IPC, and we look at the WHO's 8 core components, it looks at education, IPC programs, evidence-based guidelines, surveillance, multimodal strategies, monitoring and audit and feedback, our workload, and then built environment. And part of this is also materials and equipment for the facility that could lead to making sure that we follow and ensure that WASH is also part of IPC. So in conclusion, to ensure that we don't spread, or that we don't play a role in surgical site infection, we will make sure that we clean first as an essential step in the decontamination process. We want to make sure that we do adequate decontamination of our surfaces around the CSSD, and where we use with our medical devices to prevent any spread. It's also important to increase the frequency of cleaning. So in our surgical site infection, if we do know there is happening, we need to go back to our CSSD and check all the different areas where they receive the dirty instruments, where they do the washing, and then you look at your cleaning, where they inspect, pack, and then go through to your autoclave, all your instruments that you're using, making sure all the areas can be validated, that there's nothing that could lead to a possible surgical site infection for our patients. And we need to also understand the organism's transmission route. So if we understand how the organism has been transmitted, we can break the chain of transmission, and we can prevent this by making sure that we can decontaminate and clean our instruments to prevent further spread. And here's some references, and I want to say thank you, and if there's any questions.
Wow. Yeah, honestly, I feel it's like a very heavy meal of science today. Thank you so much, Ms. Anna, for this great presentation. Honestly, I don't know how to say it, but I feel that anything that I can say, it might be perceived as this is normal to say. It's a great webinar, it's amazing presentation, all of this stuff. You are the company that organizing this. However, I wish really, if technically I can share with you the page that I'm seeing now, having all the comments coming from our great attendees for this amazing speakers panel. To be honest with you, when preparing for this webinar, I was a little bit afraid from the time that we might have almost more than 1.5 hours. And this is some sort of unusual time to the attendees. But honestly, again, I wish if you can see the comments coming from the attendees, how they feel this is amazing presentation, how they feel that it's very informative. And they mention name by name all the speakers. Anyhow, I don't want to make it more longer. And please, for the whole attendees, just forgive me. I will not be able to have all the questions coming in front of me. I think we are reaching more than even 30 something, even more. This is even out of that I received over the phone. So I'm trying to pick up questions and to share with our great speakers. So our speakers, it's up to you if you'd like to open the camera, just to have you as a panel before I'm sharing the questions. And I will, and again, for the great speakers, forgive me, I don't know which question will be for whom. I will do my best, but I'm receiving specific questions for specific speakers. And if you allow me, I will start with this one. Even this one, I do believe we received it before the webinar, and I think it will goes to Dr. Nagwa. Does screening of MRSA and decolonization before breast cancer surgery help decreasing surgical site infection by MRSA?
Yeah, screening for MRSA before surgery would help to minimize SSI rates. However, in my university, we did a study, but it was for cardiosurgery. But the same applies because breast cancer is classified as well as clean surgery and decolonization. And in this condition, decolonization is local. We never do parenteral or oral management by giving medications or antibiotherapy for decolonization. This was done in the 90s, maybe, but it is no more done. So decolonization is first screening for MRSA and local decolonization. If they are present in the anterior nerves, we apply the cream Bactroban or Fusidine in the anterior nerves. And if the swab is taken from the groin or the axilla, so in this condition, it's better to focus on patient shower using chlorhexidine gluconate. So my answer simply, it will help.
Perfectly. I'm not sure again if this is valid, but it's in the same topic. Please, I want a document about necessary of MRSA screening pre-operative. I don't know if I'm just reading the question, but I don't know, is it valid? I mean, there is like a guidelines or documents that mention it.
Sure, there are in the CDC guidelines, or if someone is following JAMA surgery. It's very specific for surgeries. So JAMA surgery.
Perfectly. I will come back again to you, Dr. Nagwa. I have some question related to you, but if you allow me, and I'm sure again, maybe this is Miss Anna, if we can help, or Dr. Amina, or again, if Dr. Nagwa wants to comment on this. It's related to the containers having the antiseptic, and the hospital is moving the antiseptic from a container to a smaller one. So the question, is it that right to do this? And what is the best practice? And does this make microorganisms grow on the containers? Again, I'm not sure if I'm doing it in the right way.
I can answer, but if Anna wants to answer, I can give my answer. I will give it very short.
Sure.
Actually, we are afraid when the antiseptics are in the diluted form. In this condition, we start to be afraid, and we don't recommend so many manipulation with the product. But if you are going to follow aseptic precautions, even to fractionate the product into smaller containers, and once used, they are discarded, no refill, so it can go like this. And I'm interested to hear the opinion of Anna, if possible.
Thank you, Dr. Nagwa. Yes, I totally agree with you. What we normally would say to people is as well that we don't want to decant into smaller containers. But we do understand that low to middle income countries sometimes do have a problem. So if they do that, you have to train your people that are working with that how to do that, and to make sure that the smaller container are completely cleaned and dry before they decant. And they have to get a container that is actually from the company or has a label on that you know, and exactly how you do that. Because we know that people sometimes leave a little bit behind. And we found with research as well that there is some organisms growing there, and you can actually transmit that through there. So yeah, definitely, I totally agree. Thank you.
Perfectly. Thanks, Ms. Anna and Dr. Nagwa. Dr. Amina, are you with us, or because I know that my Dr. Amina, just confirm to me if you are here. Okay. If not, I will take just another two very quick questions, because if the great panel allow me, I have some questions related mainly to povidone iodine, but I will leave it to the end because I will collect all of them for this question and I will take it. So I'm just taking the general question and the question related to your great topics. So there is a question here is how we decrease the rate of infectious at site of surgery in case of potential septic operations.
It is simple. Apply the bundle and specifically stick to the restricted formula of antibioprophylaxis for clean contaminated surgery.
Ms. Anna, if you would like to comment or to add.
Yeah, I totally agree with Dr. Nagwa as well. You know, as Amina also mentioned, you know, timing when you do the surgery and then also cleaning of the operating theater. That is also part of, you know, ensuring this. But definitely the bundles and then taking the precaution with the prescribing antibiotics before they start and following through on that. I don't know. I see Amina's now on. Maybe she just wants to add on. Thank you.
I don't think Dr. Amina online. I do believe that she might leave because she had a personal issue. So this is enough your answer, and Dr. Nagwa as well. Dr. Nagwa, this question is targeting to you by name. This is I receive it like this is for Dr. Nagwa. Just a second. Who's here? because well, يعني, okay, it's a very huge questions. Is there any evidence-based data why prolongation of prophylactic antibiotic in surgery is not recommended as a parameter to decrease surgical site infection? And the second part of the question, and do you think using a single or maybe 2 doses of surgical prophylaxis may increase the chance of developing antimicrobial resistance?
Already we are facing a catastrophe regarding multi-resistant bacteria. It does exist already. And about asking if there are any evidence-based data regarding the prolongation of antibiotic after surgery, my answer will be, even with the clean contaminated class, I'm giving antibiotics just to help for the to avoid the proliferation of any remnants of bacteria that might contaminate the field of the surgery. But it is not the only factor that will have a role, if any, for the occurrence of the infection. So, as a rule, when we do or formulate antibiotic prophylaxis policy in a hospital, we put set of antibiotics to be used, whether which class of surgery. And again, for the clean surgery, it is recommended not to give antibiotics, by the way, and still we give. So the prescription of the antibiotic already for prophylaxis is evidence-based. This is not something that came to our mind and we said, so we are going to put such antibiotic, or sometimes if you have some business with the pharmaceutics, it is not the case. So it's already evidence-based. It specifies the name of the antibiotic, its dose and duration, because afterward, if I am prolonging the use, it will be not effective. I'm not treating infection, so I'm waiting for what? Actually, if I use the proper dose for the proper time, and I did proper pre-operative preparation of the patient, and I was ensuring accepted parameters to do the surgery, from where will come the bacteria? So let's be smart in managing surgeries, in managing their prophylaxis, because prolongation of the time has not been evidenced to improve the outcome or the results. This is my answer.
Perfect.
The second part of the question was what? I don't remember.
I forget it, but I can reach it now, Dr. Nagwa. This is, yeah, okay. Even I thought that you have both of them, but yeah, okay. And do you think using a single or maybe 2 doses of surgical prophylaxis may increase the chances of developing antimicrobial resistance or resistance?
Sure. Sure. This is kind of abuse of antibiotic therapy, or it's not a therapy. This is what I'm stressing upon. It's not treatment. It's not therapy. It's prophylaxis. So why not to use it as prescribed?
Well understood. This is again, I'm so sorry for the attendees, but for the time and for the speakers, we have a long time. This is the last question before I go for some specific question related to povidone iodine, and I will leave it for Dr. Amina or Ms. Anna. The question is, if the laryngoscope not autoclaved, not autoclavable, or cannot remove lamp, alternative Sedix or alcohol, what is the best?
The question, I am available. I just want to say it's up to, like if the question is for Anna, I'll just give the floor
Yes.
for Anna.
No, go ahead,
Because
Dr.
she's-
Amina, and we can hear any comments from Dr.
I will just say from my perspective
Yes,
from OR, everything, it just follow the instruction of use of the item. What is written on the item? I can't say, if the item says that you will use it or autoclave it in this way, you have to follow that. The laryngoscope, it depends. If they are autoclavable, and it even mentioned how many times it should be autoclaved, what temperature you will use, what machine you will use. The other methods that we are using, it's really you are violating the manufacturer instructions. Of course, you are putting the patient at risk. I can't add anything else. I can't say more than manufacturer says, you know. So whatever IFU says, I should follow. So follow the IFU, instruction of use on that particular item, how it should be autoclaved. And I'm sure Anna will agree with me on that, and she can add on this.
I totally agree, Amina. There's nothing else to add. We have to follow instruction from the manufacturer, because otherwise we'll damage the instrument and it can be damageable to the patient. So we have to put the patient first, so we follow the instructions. Thank you.
Okay, the last very quick question again for Dr. Amina and Ms. Anna as well. Is it possible to re-sterilize the mesh used in incisional hernia operation using an autoclave?
I can see Anna, because she's in the video, that I agree with her also by nodding the head. Not definitely. Again, the answer is go to the IFU. We never re-sterilize things. It is everything is single use. You are violating the rule. You're putting your patient at risk of infection. And you don't know this item which is used. If you re-sterilize, it will be safe. It will serve the same purpose it was meant to be at first or not. So always follow the instruction. If the single use symbol is there, you never ever violate that. That is for our patient safety.
Perfect. Very, very well clear. Last but not least, and this will be very quickly, I will not take more than 5 minutes, the last 5 minutes before the closing. Very quickly, Dr. Nagwa, Ms. Anna, Dr. Amina, and again, this is specifically for Bovidone iodine, and believe me, it's not a branding or promotion. Again, I think it's a valid question. We need your expert and experience even on daily practice for this. For example, and this is, I will consider even a general question not related to Bovidone iodine. For all antiseptic, we know we have the brand and the generic, and both are there. From your perspective, what is the difference and how to say it in a very short statement, brand is better than generic, or they are equal, or whatever. Let's start with Dr. Nagwa very quickly, then Dr. Amina and Ms. Anna.
Would you clarify more? You want to know the difference between the brand and the generic?
In general, I'm not mentioning Bovidone iodine, but let's say whatever antiseptic, I think most of the antiseptic now, we have the branded one and the generic one for this one.
Yeah.
For your experience.
Yeah, I will answer your question frankly. Actually, I do testing of antiseptics and disinfectants. Okay, I do this in vitro, and for the antiseptics, I do it on the skin, whether for colleagues working for specifically if I'm going to test a hand antiseptic for the alcohol-based hand rub, or to test a product if I'm going to use it for a patient like your Bovidone iodine on the skin of a volunteer, not a patient, to find out the effect on the skin, because antiseptics are a bit different than disinfectants, which are used for inanimate objects.
Right.
Yeah, from my experience, and this is frankly speaking, testing the brand gives 100% good results. And when we work with other products with the formula, but of course with different additives because it's a different product. Yeah, we agree that it's the generic. It has the povidone iodine, for example. It has the ethanol 70%, but due to other additives, sometimes, for example, for the alcohol-based products, this might minimize the percent of the alcohol in the product itself, you know, so the effect will be impaired. This is from my experience.
So if I will take it very simply, Dr. Nagwa, I will say that I'm recommending
the brand, whatever the product.
Yes, to do the test and be yourself assured that whatever are using is giving you the expected result. That's it.
Exactly. Yeah, exactly.
Perfectly. I don't know, Ms. Anna, Dr. Amina would like to have a quick comment on, because this is honestly a sensitive topic, brand versus generic. And I don't want to take it specifically for povidone iodine or whatever, but I need just to make it general. So I do like the answer coming from Dr. Nagwa. Simply, you need to do the test and to be assured by yourself that you have the expected results, and then go ahead. If you would like to add anything, Ms. Adna?
I totally agree as well with Dr. Nagwa, because there's so many brands on, you know, and so many generic products on the market. You have to test, because a lot of them say the same thing as the branded one, but you're never sure what's in there. So you have to double check and see. And we found that the ones that are branded, that we know from reputable companies, are much better than the ones that are just arriving and coming and going. We call it fly by night. You know, 1 minute they're there, the next minute they disappear. And we found that a lot of them have different effects on people's, if it's antiseptic, on people's hands. Sometimes you do get a rash or you know, inflammation or anything like that. So I would also agree, go with the branded one. Thank you.
Perfectly. Thank you so much. Dr. Amina, 3 questions in 1 question. And again, it's related to povidone iodine. Very quickly, can we use it as a shower for the patient before surgery? And what is the optimum time? And should I put it on the skin or wash it or keep it for more effectiveness?
How to use the item and how much time you have to follow the instruction. I always agree with manufacturer. They are the one who did a test, they did the research, they did everything, and they're the one who decide. Actually, I totally agree with Dr. Najwa. Of course, we do test ourselves the items and do the testing. Do we use it? Chlorhexidine, actually, in our organization, we do use chlorhexidine as a shower for our patients, and we follow the instructions what is really given. And I can't add more on what Dr. Najwa and Anna has really said regarding that.
Perfectly. Again, this is more than enough. This is a very heavy meal. And if you allow me, I would like to thank all of you, our great attendees and our amazing speaker today. And just very quick points from my end before closing. Number 1, related to our attendees, thank you so much for your time. Just to assure you that we already submitted, as per the registered names, your good names for the Royal College accreditation. And as per our agency, it might take from 4 to 6 weeks from now, after the event, to receive the accreditation of 2 hours from Royal College. And it will be sent to you either by email or hand to hand. It depends on the situation. But just let's give us like 1 month, and then you have this one. For the great speakers, there is nothing to say. But again, I'm so happy with the feedback that I'm receiving, the comments in front of me. Just very quick points. I need your approval, if you don't mind. Number 1, and this is specific to Dr. Nagwa, please allow me personally to use the slogan for any event related to infection control. I like it so much. So if you don't mind, I will use it for whatever. This is coming from the comments in front of me. Many of our attendees are asking if they might have your kind presentation in PDF. So just if you don't mind, we can share it with anyone needs your current presentation for this one. Last but not least, as you know that having the accreditation from Royal College is giving us a patent for 1 year. Once we use this recorded presentation or webinar anytime, we will have the same accreditation for another attendees. So I'm asking your permission that we might use the recorded webinar in different countries in Middle East, Africa, and for almost 1 year, and attendees will have the same presentation, and then they will get the accreditation. So if you don't mind, I consider this is approval from your side. The last thing that I would like to thank the agency and the organizing company for this one. Again, I'm not saying this as a compliment, but this is one of the most efficient and science behind webinar, and the people are really very happy with this, despite it's almost 2 hours without break. But the comments is encouraging me to say that thank you so much for the great speaker that we have. This is not my first time with Dr. Nagwa. She is like, I don't know what to say, but I will not say it in a formal way. But yeah, she is like, yeah, I keep saying that in the infection control, if we are saying that Egypt had the pyramids and had the beaches, the weather, in infection control, Egypt had Dr. Nagwa Khamis. And this is the best simple definition for Dr. Nagwa. Yeah, and we are proud as Egyptian to have Dr. Nagwa as international speaker. Ms. Anna, my great honor having you for the first time, but I'm sure that it will not be the last time. My colleagues in South Africa are so happy that you are with us, and I'm quite sure in the next coming future we will have you more and more in South Africa locally as well, using this webinar for this one. So thank you so much for being with us tonight and today. Dr. Amina, despite your situation, thank you so much that you attend the webinar and even attend the session of question and answer. I'm lucky enough that I'm in UAE, based in UAE, so it's easy to meet you, and will be my honor to meet you personally very soon as well. My colleague Rudaina, marketing manager for GCC, is planning for an amazing week for infection control. So I do believe that Dr. Amina will be with us by way or another, using the same webinar, this amazing webinar for this one. Just to make it very clear, I don't have any other thing to say more than thank you so much, our great speaker. Thank you so much, our great attendees, for your time. See you soon, and God bless all of us. Thank you so much. Shukran jazeelan.
Bye-bye.
Thank you.
Thank you.
Bye-bye.